Hi there, it's Rob Arnfield speaking to you once again. And today's screencast is going to cover the topic of valvular assessment using point of care echocardiography. This screencast will fall into a suite of different screencasts that you've undoubtedly seen on the Institute discussing more sophisticated topics related to point of care echo. As part of this screencast, which is among the more sophisticated of the series, I will make two assumptions. First, that you have some comfort with the basic 2D echo views, as we will not review these in much detail during this lecture, and that you have some understanding of the basic Doppler principle, and that includes the understanding that cuts that are parallel to blood flow are generally superior for resolving flow through Doppler interrogation. So when it comes to assessing valves, a distillation of this topic into a compact and manageable size and intellectual scope for point of care is more challenging than some of the other topics that we have covered, including the pericardium, the left ventricle, the right ventricle, hemodynamics. Valves really define the boundary between the fundamental echo that every resuscitative doctor should know and advanced echocardiography, which is the realm of the cardiologist or a advanced trained echocardiographer from another discipline. And in general, when assessing valves, a more liberal threshold for escalating to expert advice and a humility regarding the room for error must be entertained. The goals of a point of care valvular assessment are twofold. The most important and first priority is to identify devastating left-sided valvular lesions. These include acute severe mitral regurgitation, severe aortic regurgitation, and endocarditis. That is, to rule in these conditions, not to rule them out. Of importance, but not of necessity, is to identify lesions that will complicate your management of any patient with cardiopulmonary failure. So identifying features that may be suggestive of stenotic lesions or regurgitant lesions of the other valves or systolic anterior motion. Now, detailed assessment of these conditions requires extensive additional training, and in many cases, you may only be left to hypothesize the presence of these possible lesions, and as mentioned already, will lead to an early escalation to an advanced echocardiographer to clarify their presence or absence. Of distinct disinterest to us is any valvular lesion that starts with the descriptor physiologic or trace to mild. Similarly, it is not the objective of the point of care echocardiographer in the most basic sense to rule out valvular disease. So as mentioned, lesions of particular interest to those of us managing acute circulatory failure is to assess for the presence of severe mitral regurgitation, and especially those lesions that might be acute, as chronic severe mitral regurgitation may be present and not necessarily the culprit for what is happening. We'll review this concept later, but in the meantime, severe MR in the acute setting may be caused typically by three problems: ruptured papillary muscle, typically in the setting of an ischemic event, an endocarditic lesion that may have destroyed the valve itself, or more rarely, a traumatic valvulopathy. Moderate or severe aortic regurgitation may be seen acutely in the context of endocarditis, aortic dissection, and again, a little more rarely, but genuinely, a traumatic valvulopathy of the aortic valve. So how do we assess valves? What tools do we have? Well, we have 2D techniques, which should be familiar to everybody, of course, through general inspection of the appearance of a valve, requiring your eyeballs, or in a more detailed fashion, planimetry in the diagnostic echo world. Color techniques are multiple as well. Most commonly used are jet area, assessment grossly for the presence or absence of turbulent flow, may indicate the presence of a stenotic lesion. Vena contracta, which we will discuss, and PISA, a more sophisticated technique, which we will not discuss in any detail in this screencast. spectral Doppler techniques, and we reviewed Doppler separately, so some of these concepts may be familiar to you, and we'll review a couple of them later on in some cases, include a pressure half-time, as is commonly looked at with the aortic valve, looking at peak and mean gradients for stenotic lesions, and the presence of flow reversal in the aorta in particular for aortic regurgitation, or in the pulmonic veins for mitral regurgitation as well. With the advent of 3D technology, assessment of valvular lesions using 3D is very common in the advanced and perioperative echocardiography worlds. For the sake of our discussion today, and in keeping with resuscitative echo guidelines, we will discuss 2D and color techniques for the most part. An old set of guidelines, which I'd recommend to you if you are deeply interested in this topic and want to understand the full extent of valvular assessment, would be these guidelines from the European Journal of Echocardiography from nearly 15 years ago. So we spoke of the first tool, which is a 2D technique, and the eyeball technique of looking at the valves, not unlike our gross assessment in other domains of point-of-care echo, should be routinely applied. Assessing the valves with your eyes involves looking at the valve itself, looking for the presence of calcifications, looking at the relative mobility of the valve leaflets, the presence of thickening of the valve leaflets, and the presence of any masses or lesions which may be attached to the valves. So by way of example, here is a parasternal long axis view of the heart, and we have the aortic and mitral valve in plain view, and we can address each valve separately, but we're looking at the mitral valve. We can see that the valve leaflets open freely, they are not thickened, and there don't appear to be any masses or lesions attached to the mitral valve. Similarly, the aortic valve is thin, pliable, opens freely, does not appear stenotic, and looks quite good. So this 2D assessment alone, including the coaptation points of the valves, I must stress as well, where the valves meet each other in the middle and are coapting in a normal fashion, is of great value, as most valvular lesions that are severe will initially be evident prior to applying any Doppler or color techniques to the image. So I really encourage you to use your eyes to start with before considering color screening any valve. By way of comparison, we have a 2D image here of the heart from an apical four-chamber perspective, looking at the tricuspid valve on the left and the mitral valve on the right. We can look at the tricuspid valve. We see that the valve, again, is thin, generally opens well, no obvious lesions or thickening. We turn our attention to the mitral valve, and we see quite obviously that there is malcoaptation of the anterior and posterior leaflet. In particular, though EKG is lacking from this clip, we can see that the posterior leaflet is coapting behind the anterior leaflet, and this is actually happening throughout the entire phase of systole. So even before applying color or evaluating the severity through Doppler techniques, we can say that this is severe mitral valve failure, as this is diagnostic of a flail mitral valve leaflet. More 2D assessment here. We see another parasternal long axis view. We see the aortic valve, not quite as thin and pliable as the initial clip we saw. We see the right coronary cusp is opening reasonably freely, but the left or non-coronary cusp appears to be a bit more calcified and perhaps more fixed. Unclear clinical significance, but all the same, we're using our eyes to address this. Then looking at the mitral valve, however, we see a distinctly different geometry and morphology compared to our previous normal example. We see some degree of thickening at the distal tips of the leaflets, and we see a distinct pattern of restricted opening and a somewhat crooked geometry during diastole, also referred to as diastolic doming, which is highly suggestive of mitral stenosis. This is not diagnostic of mitral stenosis. That requires spectral Doppler techniques typically to address its severity. But again, this eyeball technique will serve us well in pattern recognizing obvious anatomic distortions to the valves prior to going any further with other techniques. Lastly, Here is another parasternal long axis view, and I want to turn your attention to a more subtle finding where we see here the aortic valve looks reasonably normal, though the aorta itself looks a bit dilated. And we see the mitral valve here, which actually opens pretty freely. But of note, during diastole, we can see the anterior leaflet. And if you subtly look at it, I hope you may see that the anterior leaflet actually is reverberating or vibrating during these diastolic periods. And there's one right there is the easiest way to see it at that end of this loop. You'll see it hovering in diastole, and you can see it, that vibratory movement. And we'll come back to this in a moment to explain what that is. But again, more clues about valvular dysfunction just through 2D assessment. A apical four-chamber view here. Again, 2D assessment of the mitral valve in particular. We see during systole, we can see the anterior mitral valve leaflet being pulled in towards the septum quite close, in keeping with anatomically confirmed systolic anterior motion of the mitral valve. The severity, again, of this is clarified using Doppler, but initially is picked up very easily by looking at the valve carefully with your eyes. So having proved to you the merits of an eyeball technique, we can then move on to the most common method by which valvular lesions are screened for their severity, which is the use of color. Now, color Doppler is derived from pulse wave Doppler physics, as you may recall, and really it assigns a color map to the direction of flow and allows us to evaluate how much flow, very subjectively, may be going in the wrong direction or maybe accelerating in flow, leading to aliasing. And for those discussions on aliasing, I would refer you to the screencast that we did already on Doppler and hemodynamics. So in looking at that original clip we saw with the flail posterior mitral valve leaflet, we can see the effect of applying color to this valve, which we've already deemed as being severe mitral regurgitation or severe mitral valve failure on account of the anatomic findings. But we can see here that during systole, though it's quite rapid, we can see the complete opacification of the left atrium with color, suggestive of the severity of this mitral lesion. Of note, this color box is probably a little too large. In general, when evaluating a valve, you want to cover the affected valve and the receiving chamber when evaluating for regurgitant lesions. So in this case, we could narrow the size of the color box and just cover the valve and the left atrium. We'll talk a little bit more about that technique a little bit later. Now, as I mentioned to start the screencast, parallel flow is of particular interest to us in Doppler because Doppler technique is optimized when flow is parallel. I want you to know that non-parallel visualization of flow can still occur, and that especially is valuable in the parasternal long axis, where the two valves of particular interest to us, the mitral and aortic, are visible in the same image. This allows us to quickly screen for the presence of mitral and aortic regurgitation. Again, the operator here has demonstrated a slightly lazy technique of addressing both valves simultaneously with the color box, which wouldn't necessarily be the preferred technique, but all the same, I hope many of you have already identified that this blue jet during diastole here is suggestive of aortic regurgitation. Not a severe amount of regurgitation, as we'll review shortly by color criteria, however, present all the same, even though we aren't parallel to the aortic valve. Similarly, I feel confident that the mitral valve here, though it may occasionally show a trace amount of regurgitation, really is not showing any meaningful regurgitation that would be of concern. So the bottom line is non-parallel assessment of flow is useful still and can be used to largely exclude devastating lesions by color criteria, even though you aren't parallel. So we've talked now a little bit about color criteria for severity, and the color cutoff I want you to know for the left atrium and for mitral regurgitation in general is a color jet that occupies more than 40% of the left atrium by eyeball method is generally considered severe. Now, this is extremely fraught with limitations, especially because if you can imagine that the amount of blood recruited into this chamber through regurgitation depends enormously on the strength of contraction of the ventricle, and in particular, the amount of pressure in the left atrium. So that is to say, color size is actually a load-dependent situation. So a patient with a low left atrial pressure who has been, say, diuresed for heart failure may show slightly more regurgitation by color criteria than they did when they were volume overloaded with elevated left atrial pressure. So load dependent makes color a little imperfect to make enormous decisions on, but I would say confidently that all point of care and even diagnostic laboratories start with color as their initial screening technique of choice for valves. Other criteria for severe mitral regurgitation are listed below, and without going into them in any great detail, I want to comment on vena contracta, which is, if it's greater than 7 millimeters, is a severe lesion, and we will review that in a moment. Severe aortic regurgitation by color is a lesion that occupies greater than 65% of the left ventricular outflow tract. So we can see here, again, a non-parallel example of aortic regurgitation, and we can see that during diastole, the blue jet, which you're seeing here, is easily occupying well more than 65 and nearly 100% of the LVOT. Similarly, this is subject to loading conditions. So if a patient with moderate aortic regurgitation might go on to meet severe criteria if they develop sudden systemic hypertension, pushing the gradient of regurgitation more in favor of more backflow. Other criteria for severity would include a ratio of jet area to LVOT area greater than 60%, a vena contracta greater than 6 millimeters, and we will review what a vena contracta is shortly, I promise you, and some other features which we'll actually review in a case later on that we will go into. So the vena contracta I've mentioned now a couple times, and the vena contracta is identifying the narrowest region of central flow at or downstream to the orifice of a regurgitant valve. This is not straightforward to apply at point of care most of the time because the resolution frequently in our critically ill patients, as is often the case when frantically assessing a valve, doesn't always allow for an accurate measurement. Often I find this most helpful when I'm doing transesophageal echo at the point of care because the resolution of both the valve and the jet is sufficiently high that I can measure this distance here, this width. And the nice thing about vena contracta is that it doesn't get all influenced by the loading condition. So it's relatively load independent, and it can also be used to help clarify central jets, but also eccentric jets. So jets that may be wall-hugging jets, as they're called. So jets that may not be through the central part of the valve, so a leaflet perforation or a prolapse or flail that produces a jet that wraps around the side of the wall of the receiving chamber. We can still use vena contracta to gauge their severity, where color would underestimate their severity. So this is a useful technique, and the cutoff values of note would include in the aortic regurgitation setting a VC of greater than 6 millimeters, and in the mitral regurgitant setting a vena contracta of greater than 7 millimeters. But it's important to note that when measuring millimeters, it's easy to make a mistake here or just overestimate or underestimate. And so the values are really quite narrow here. And in general, this is why excellent resolution and TEE is my preferred way of using vena contracta. But important to know about and understand, as this would represent the most logical and easiest application of a valve stratifying technique, a severity stratifying technique, the easiest one after color Doppler. And so here would be a great example of a TE image from the mid-esophageal four-chamber view zoomed in on the mitral valve. And we can see here this lesion here, this mitral valve lesion, very clearly the narrowest region of the jet at the valve orifice is measured. And though it's not seen on the screen here, this measured up at 9 millimeters and was consistent with severe MR. And you can actually see this jet is actually going off to the side a little bit. So that might be a little bit eccentric. And so the amount of area of the left atrium occupied might approach 40%, but by color criteria, this would be iffy, whereas by vena contracta criteria, it's actually very obviously quite severe. So when talking about color, I want to emphasize a few acquisition pearls. In general, color, when added onto a 2D image, taxes your ultrasound machine, and especially at the point of care, this ultrasound sparing approach is important. So what you want to do when imaging the 2D image, you want to minimize your imaging depth, and you also may choose to narrow your image sector size of the actual 2D image. And when it comes to applying the color box, as I mentioned, you want to use the smallest color box that overlaps the valve of interest and the chamber of interest. This will help you resolve the valvular lesion most accurately. Being aware of the trigonometric applications and influence of the Doppler technique, that parallel blood flow is most accurate, though we've talked a lot about how non-parallel flow can still be used. If you really have a lesion of interest, it makes a great deal of sense to do your best to look at that in a parallel fashion. Also, be certain to set your color Doppler ideally as high as possible, and typically in the 60 to 70 centimeters per second range, though sometimes because of imaging limitations, including having to image at high depths, it may dip as low into the 40s, but ultimately the higher it is, then the less aliasing you will have and the more accurately you can portray the jet. If you have lower Nyquist limits, it may overestimate the size of your jet. If you think you have a large color area, be certain your Nyquist is as high as you can set it on your machine. And color gain, though, is not generally a problem. One should be aware that by adjusting the gain of the color Doppler setting using typically the same gain dial as is for 2D gain, you may either underestimate or overestimate the degree of color, and one should be careful to ensure that if you believe the color gain is off, you may take the probe off the patient with color Doppler on and turn the gain up until you see spontaneous color speckling with the probe just not even on the patient, and then turn it down so just beneath the threshold where the speckling disappears is the way to titrate or calibrate your own color gain, though again the machine will typically do this for you. An important pitfall with color is, just as in with any disorder you see on echocardiography, is that the severity of what you see doesn't always mean that it's hemodynamically important. And this quote from the guidelines I mentioned earlier, I find of particular value, that somebody who develops a acute regurgitant valve for an unaccommodated or unadjusted left atrium may be easily overwhelmed and result in something of great cardiopulmonary importance. And whereas somebody who has had a long-standing valvular lesion is well adapted to it, and if you're getting to see these valves for the first time, it's easy to be swayed by the amount of color you see, but being aware of the clinical trajectory is critical. So by way of example, we have these two cases which present with strikingly similar apical four-chamber views. And case one is a patient who presents with a progressive history of shortness of breath over 1 month. And case two is a patient who presents with a 1-day history of chest pain followed by sudden, severe shortness of breath. Now, the clinical history here is the distinguishing factor that tells you that though these echoes look largely identical, and in fact obviously are identical when you look at them closely, that in the one case, case two, the clinical stem combined with that burden of mitral regurgitation, which would be approaching severe, may very well make that regurgitant lesion a culprit finding. That is, may be responsible for the shortness of breath. Whereas in case one, we'd call that more of a complicator. It's certainly not helping the gentleman's shortness of breath, but after a month is unlikely to be an acute event that in and of itself is capable of causing the presenting problem by itself. And we talked a little bit about eccentric jets already, and I want to remind you of this principle again, that eccentric jets are severe until proven otherwise. And so here we have a case where we have a peristernal long axis view. We don't show you the 2D image, but there is a leaflet perforation, and the anatomy isn't as important, or the underlying pathology isn't as important as recognizing that this jet, though the color box should ideally cover the entire left atrium, is really sort of indistinct. It doesn't fly backwards in the nice sort of laminar fashion we're accustomed to, and in fact is centered all of the valve. There's a ton of turbulence happening here, and the jet sort of shoots off and dies on the back wall here of the left atrium. So by color criteria, this would be a little bit underwhelming, but it's because it's a eccentric jet, it's shooting off to the side, that it doesn't get your fair attention. And so be aware that these jets are kind of wolves in sheep's clothing a little bit, and you want to pay attention to them very seriously. And again, these are usually due to quite malicious valvular pathology, such as flail leaflets or perforations in many cases. So severe until proven otherwise with eccentric jets. We've commented a little bit earlier on endocarditis, and I want to mention that while endocarditis is undoubtedly an advanced concept to rule out, it will occur frequently for the point of care user who does enough echo that you will stumble across meaningful valvular vegetations. And for the point of care user, a vague understanding of what you should be looking for is important. On the tricuspid valve, we see here on the left, we have a very obvious density mobile mass attached to the tricuspid valve that is consistent with endocarditis. The aortic valve here on the peristernal long axis is not as obvious. However, you can see that the valve is greatly thickened, and I hope you can also see there's a pedunculated kind of mass attached to the right coronary cusp. And of note, in both of these situations, you'll see that the bulk of the vegetation actually lives on the lower pressure side of the valve. So in the tricuspid valve, that would be the right atrium. In the aortic valve, that would be the left ventricle side. You can imagine as an organism surviving, the lower pressure environment is favorable for these bacteria or fungus in most cases to survive. So looking for the correct side of the valve. And this mitral valve lesion we see here similarly living on the atrial side of the anterior mitral valve leaflet. So those are the principles of endocarditis. Again, I want to emphasize that we are not endocarditis excluders, but ruling it in and elevating your suspicion with point of care echo is something that is perfectly within your skill set once you become familiar with 2D inspection of valves and their appropriate thicknesses and mobility. Let's now talk about a couple valvular cases. The first case is a 45-year-old male, previously healthy with shortness of breath and chills, and presents to your emergency department with the vital signs below that are somewhat non-reassuring and febrile with some hypoxemia. And the intern assesses the patient and presents to you a stethoscope finding of a possible murmur. Acknowledging that murmur is generally caused by a valvular condition, you now apply your echocardiographic skills and inspect the valve. The peristernal long axis is available to you here. We turn our attention to the mitral valve. We see some restricted opening of the valve. We see poor or modest resolution of the valve, but no obvious masses or thickening. However, the aortic valve is striking, whereas normally the aortic valve, especially in a young male, would be very thin and pliable leaflets. The leaflets here are extremely thickened and visible, and immediately your suspicion in this febrile patient, given the clinical context, turns to a possible endocarditic lesion. Color is then applied across the valve and the LVOT, and you can see a torrential flow of blue flow, which is away from the transducer during diastole, highly suggestive of aortic valve failure in this case. And at this step alone, you've now immediately made a diagnosis of, most likely diagnosis of endocarditis, pending blood cultures, of course, and can influence the patient's management accordingly to perhaps the appropriate service or center that might be able to deal with the complications of this condition. And so just to ram it home, though, once you identify a valvular lesion, you assign its relative importance. And so aortic regurgitation and severe, as by color criteria greater than 65% of the LVOT, as we saw in that image, this would be acute severe aortic regurgitation, and this is a life-threatening event. And so by identifying a potential catastrophic lesion, we then can reference what potential actions, and referring to a surgical center or an appropriate center where surgical consultation can occur would be a priority in this patient, and how echo at the point of care would have influenced the patient trajectory here. On an advanced level, there's some advanced assessment of severity, which you can do easily, especially if you're already familiar with aortic assessment in the abdominal aorta using either pulse or typically pulse wave Doppler or a continuous wave could also be used in this particular image to look for reversal of flow during diastole, indicative of severe aortic regurgitation. In this case, sort of an interesting finding that generally is saying the bottom is falling out of this patient's circulation due to the severity of the aortic regurgitation during diastole. Case 2 is a 56-year-old male referred to the ICU for pneumonia and ARDS after 2 days in an outside hospital. The chest x-ray is remarkable for bilateral airspace disease, totally consistent with the presenting diagnosis, is admitted to your ICU. However, an astute physical examination reveals a systolic murmur once again. And again, we are now called to action with point of care echo to evaluate the valves. Now, this patient, because of their tremendous positive pressure ventilation settings and airspace disease, really only had a subcostal window that was available by transthoracic echo. We apply step 1, our eyeballs. We look at the valves. Well, we see a subcostal view. We see the tricuspid valve in the near field. It looks thin. Don't see too much going on there. The mitral valve is seen here, and it looks a little unusual. And I must say, at first glance, it's not immediately obvious what it is that's unusual about it, but it appears, though the anterior mitral valve leaflet is almost has 2 planes to it, and so it makes me suspicious there's pathology there. As well, I note that there's something odd about the septal appearance here, but trying to tie this all together, given the history of pneumonia and ARDS, is not immediately evident, and this isn't consistent with the clinical history we're shown, so we're going to go deeper. We look at the peristernal short axis view. We see what appears to be vigorous LV function by eyeball method. But again, we note something very curious here, that the septum appears to have an aneurysmal portion to it, which is a little bit different than a young patient with pneumonia and ARDS we'd expect to have, and makes me concerned that we may have missed an ischemic event at some point in this patient. And lo and behold, now the valvular assessment demonstrates a significant mitral regurgitant jet, which completely opacifies the left atrium as we apply step 2 of our valvular technique. And we now can identify we have somebody with severe mitral regurgitation by color criteria, and we now must move on to assign the relative importance. We've identified that we believe there's a potentially catastrophic lesion associated with severe clinical trajectory of bilateral airspace disease, which seems unlikely a patient would have pneumonia, ARDS, and severe mitral regurgitation from a clinical point of view. So we have to then reconsider the diagnosis, especially now with a basal septal aneurysm that likely this patient at some time actually underwent an ischemic event. And this is not infectious at all, which when upon further history, there's been no positive cultures for pneumonia. We're now starting to rewrite this patient's story quite a bit with respect to their illness. And we have to decide what to do next. So management for severe mitral regurgitation, so afterload reduction, diuresis as possible, heart failure management. But of course, surgical consultation is warranted in this case because the patient's now critically ill with a mechanical valve issue. And of course, asking for a more detailed echo assessment from an advanced echocardiographer are all appropriate actions in response to this case. A TEE was then undertaken, and you can see here a lot of the same findings from this mitral commissural view, where we can actually see the scallop of the anterior leaflet with a piece of the papillary muscle attached to it from this patient who has a papillary muscle rupture associated with the ischemic aneurysm is evident, and the patient was referred on for cardiac surgical management of this problem. So I want to now summarize the frontline integration of valvular assessment. Your primary objective, to rule out severe regurgitant lesions using your eyeballs and color on the left side. Your secondary objective, assess for important valvular lesions that may complicate your management. Those are the stenotic lesions. Those are the moderately regurgitant lesions. Those are the tricuspid lesions of any kind. So step 1, 2D evaluation of the valve. Step 2, assess with color for MR or AR. And I use a classification which is quite simple at my center. I encourage others to use it. It's either severe or it's not severe by your assessment. And if it's severe, you would escalate emergently to an advanced echo. Non-severe lesions, you'll probably want to still clarify their importance and may ask for an advanced echo at some point, but not necessary to do in the middle of the night. Step 3, you may assess for stenotic lesions. And again, you may, if you have the skill set to use spectral Doppler, clarify them as being severe or non-severe. We aren't going into the details of how to assess for stenosis in detail in this screencast. It's a much broader topic, but that would be the same heuristic pathway. And then once you've identified any of these lesions, you assign a relative importance of the lesion. Devastating, important, or incidental would be an example of the terminology I use. So when you assign the importance of these things, so devastating lesions like we reviewed, like endocarditis, acute severe MR, acute moderate to severe AR, those generally result in immediate escalation. Important lesions like severe AS, severe MS, systolic anterior motion of the mitral valve, or severe chronic MR or TR, this results in changes to your hemodynamic strategy for that valve lesion. It might influence the way you intubate somebody if they have severe AS, of course. It may influence your beta blocker therapy for severe mitral stenosis, your fluid administration therapy, and inotrope choices for somebody with systolic anterior motion. These are all very important things and more advanced hemodynamic considerations. And if you don't have an advanced echo skill set, you may wish to employ one in a semi-urgent fashion. Incidental would describe all the other lesions not described here, and in general, no immediate action is required. Again, if you need clarity, diagnostic, or comprehensive echo done by an advanced echocardiographer would be a reasonable choice, given that we've acknowledged you must be humble about the complexity of assessing valves, and when in doubt, escalating is a very reasonable choice. But I hope I've armed you with sufficient techniques in this screencast to be able to take some matters into your own hands, and in particular to rule in lesions that you might otherwise miss or might go unnoticed for hours or days, when hours and days aren't friendly to the patient's condition and may therefore save a life or certainly expedite the right care at the right time for some patients. So this concludes this screencast. I hope you've enjoyed it. We'll speak to you again soon. Thank you.